Good morning, all. On behalf of Indian College of Physicians, I welcome you all to this third module. And this module will be on skin prick test, the practical considerations, especially when we are choosing allergen immunotherapy. So we know this is a short course on basics of allergen immunotherapy. And this is a great initiation by our Dean, Professor Jyotirmoy Pal sir. So we start this course, last two module already done. Now this is the third module. And may I request all the delegates who are attending today, you have the pre-test questionnaire in your mail or even in that WhatsApp group. So you can start filling that Google form, your response on the pre-test. So it is a real honor for us to invite Professor P.K. Vedantan sir, who actually needs no introduction. He is one of the pioneers in the field of allergy and immunology. He is also increasing the allergy literacy in India. So he's trying a lot for that. So we are really thankful that sir has given us the time. Sir is currently the clinical professor at Department of Medicine, University of Colorado. And also, after his lecture, he will deliver a lecture on skin prick test practical considerations while choosing allergen immunotherapy. But after that, we'll have a panel discussion among esteemed panelists who are there with us today. We have Dr. Gayatri Pandit. Madam is now a consultant ENT surgeon and allergy specialist at Samarth ENT and Allergy Center. We will also have Dr. Krishna Mohan. Sir is MD Pediatric Medicine and he is currently the Honorary Secretary of National Allergy Chapter of Indian Academy of Pediatrics. So welcome, sir. Sir is a consultant pediatrician and allergist in Kerala. We'll also have Professor Shoibal Moitro. Sir is currently adjunct professor and senior consultant at Apollo Multispeciality Hospital, Kolkata. Sir is also a very veteran allergist. We'll also have with us today Dr. Soumya Nagarajan. Madam is also a board certified allergy and immunology from Singapore. Madam had done his primary postgraduate degree in pediatrics and also diploma in allergy and asthma. So we are really fortunate to have Madam with us too. So with that, we are not going to delay the first presentation, first lecture for today, that is by Dr. Vedantan sir. So may I now invite Professor Vedantan sir to deliver the lecture.
Good morning, Shambho. Thank you for this very detailed introduction. First of all, I want to thank you for spearheading this course along with Indian College of Physicians. I didn't realize Indian College of Physicians is more than 100 years old. It's almost 110-year-old institution, started during the British days and one of the most well-respected educational institutions in India. And I was also sort of blown off by the number of people who have been awarded diplomas and fellowships from the Indian College of Physicians. It's around 45,000 doctors. So it's a very, very well-respected educational institution in India. So I'm privileged to talk to the members of this august organization. And I thank you for getting me involved in this short certificate course, I think that's what you call, on allergy, which is a very welcome move because this specialty or subspecialty, although the allergic diseases have been around for thousands of years, the recognition of these diseases came even in the Western world only around 55, 60 years ago, although has been treated with immunotherapy without understanding the disease, the actual recognition as well as research started after the discovery of IgE in 1968. That is when, for the first time, we came to understand, this so-called allergy field is actually an immunological field. That is, the marriage of allergy with immunology occurred officially in 1968. So that is the entry of allergy into immunology. Since then, there has been a huge amount of progress. And unfortunately, the awareness has been not that great, especially in the developing countries. Even when I was in med school in the 60s, I did not know what is this allergy unless, we were basically casually would say, I don't like that guy, I am allergic to that person, this person. That type of conversation was happening. But we don't have, when now being physicians and actually being in the field of allergy, when we say allergy, we mean it as immunological reaction. So I want you to understand it's an immunological reaction. So I'm going to share slides. As usual, what I try to do is I don't go to the topic right away. Shambho, first I will do some basics. Okay. So I will run through some of the basics. It could be very repetitive for a few people, but I can't help it. But I will go through a few basics and then go to the subject matter. Nice seeing you, Dr. Saibal. So I'm going to share the screen. So the title, as Dr. Shambho was mentioning, is Allergen Skin Testing and Application of that Knowledge Towards Allergen Immunotherapy. Very interesting title, So what it means is, just because you do skin testing on a person to figure out the sensitization does not mean he has to go on immunotherapy. This is a very, very important point I'm trying to make out, because a lot of general physicians or our colleagues feel whoever gets tested, whoever has positive skin testing has to be treated with immunotherapy. So this concept has to be rectified, because you don't want to treat skin test, you want to treat the patient. So in clinical practice, in our own clinics, if we have 100 patients who are being evaluated for allergies and they go through allergy skin testing, only around 35% or 30 to 40 at the most, we will consider allergen immunotherapy. So that means 60 to 70% of patients who go through allergy skin testing may not need immunotherapy just because they are getting testing done. So this concept has to be very clear in mind, that we are treating patients, not treating skin test. Now, I'm going to cover quite a few things in this topic, in this presentation. So first we are going to go through some basics, then we are going to spend some time on skin testing. Then we are going to talk a little bit about the characteristics of allergic disease, especially what we call as progression and regression, both immunologic and clinical. And what is the relationship between all these different things we are talking about? Because allergy is a condition where we spend a lot of time on history, because that is how we make the diagnosis. The diagnosis of allergy is made, I always say, by 3 items. All my students know that. Number 1 item, history. Number 2 item, history. Number 3 item, history. So only with history we are diagnosing whether this patient has allergy phenomena or not. And then we complement our impression by doing these tests, like allergy skin testing or specific IgE determination, and you name it, several other procedures we do, so that we complement. So history plays a huge role in the diagnosis of allergic disease. Now the basics. Now we need to know that we have 2 huge parallel systems in us what we call a circulatory system and immune and lymphatic system. And the immune system is basically run by the lymphatic system. The immune system comprises of many different portions, cells, like our blood cells, platelets, mast cells, plasma cells, macrophages, tissues like skin, mucous membrane, lymph nodes, Peyer's patches, organs like spleen, bone marrow, thymus, tonsil, chemicals, all the saliva, the secretion, the sebum, the gastric juice, all these things are part of immune system. So one of the things we really have to understand is allergic inflammation occurs not in your blood, it occurs in your lymphatic system. Basically, it is the lymph nodes. That is where the action takes place. Action takes place in the lymph nodes. So if you look at, we always freely talk about T cells, B cells, but we need to know what is this T cell, what is this B cell. So T cells, the reason why it is called T cell is basically originated. These are cells that are coming out of from progenitor cells in the bone marrow, lymphocytes. They are lymphocytes. These naive raw lymphocytes enter the thymus, which is like a university. And once they enter the thymus, they get educated. What is the education and training of these lymphocytes? The training is they are exposed to the self-antigen. If they sort of recognize the self-antigen, they undergo apoptosis. You are not supposed to recognize self-antigen, because once you recognize self-antigen, that means you become a dangerous T cell to have. So they are destroyed. They go through cell death, and the cells that do not recognize the self-antigen come out as graduated T cells, and graduated cells called T cells, and that is what we call it as T cells. These are lymphocytes, and they comprise majority of the lymphocytes in our system are all T cells. 70% of our lymphocytes are T cells, and these T cells are dynamic cells. They don't stay in one place. They are circulating like police force. They are going all round and round our lymphatic system. They enter the circulatory system at their will, depending upon the call. Suppose there is some call from an infection, from some bug enters, these cells go there. So they are dynamic cells, and they are constantly on the move. Then you have got what we call as B cells. B cells are again lymphocytes, which actually get matured in the bone marrow as well as in the lymphatics, in the lymph nodes, and their main function is to produce immunoglobulins. But they also have other functions too, which we are not going to talk about it now. The reason why they are called B cell is because of a peculiar reason. The bone marrow that we have, which produces these cells, the analogous organ in a chicken is, there's a bursa at the cloacal region. It's called bursa fabricius, which is the analog of the bone marrow, which produces a similar type of cells in the chicken. And that is how the name B cells was derived. I don't know the logistics, the reasons behind it. Dr. Saibal might know, and he probably can educate us more about why it is called B cells. Now, the important organ that you need to know is lymph nodes. We take it for granted. Oh yeah, it's a little bit swelled up, a little tender. But why is it a little bit tender? Why is it a little bit enlarged? Because of inflammation. Inflammation means a lot more activity. When you have more activity, you get swelled up, you get swelling. That is a characteristic of inflammation. And allergic inflammation causes the lymph nodes get to enlarge and also a little painful. It's not infection. The reason for that is there are T cell zones and B cell zones in the lymph node, and this is where the T cell B cell interaction takes place. And that is where the allergic inflammation takes place. That is where the antigen presenting cell presents the antigen to the T cell, and that tells the B cell to go ahead and depending upon the type of interleukins, IL-4 or 13, the allergic inflammation, the Th2 driven, or if it is Th1, it basically dies down right there. So the main defect, if you look at an allergic individual, if you say, this person is coming from an allergic family or an atopic family, so genetically, this person is already wired. So what is the clinical implication of the genetic wiring that he has? The genetic defect is in the epithelium. His epithelium is weak. Every allergic person's epithelium is porous. Everybody who has got this tendency, he doesn't have to have the disease, but his epithelium is porous. He's weak. So it is a compromised epithelium. Then he has got what we call as a skewed up Th2 drive. Whenever the T cells are sort of stimulated, they tend to go towards the Th2 pathway. And we Indians, especially Asians, have a Th2 driven lymphocytes. We are much more Th2 driven than the Caucasians. And that is proved by many clinical studies as well as immunological studies done by acculturation, they call it, which I can't go through now, but we are very much Th2 driven. And this facilitates easy entry of the allergens from the environment. So one hand you have genes, another hand you have environment. So this is a classical gene-environment interaction. This is a very fashionable word that is now used. We call it, this is a lifestyle disease. Hypertension is a lifestyle disease. Obesity is a lifestyle disease. Heart disease is lifestyle disease. It's all due to gene-environment interactions. And allergy asthma is one of the classical gene-environmental interactive diseases. And I told you what is the gene defect, and you will know about the environment very soon. So the genetic defect in the environment is it's weak. The junctions, the tight junction, as well as the anatomical, physiological character of these epithelial cells are sort of compromised. In addition, these environmental agents like allergens, pathogens, pollutants, all these things have got enzymes in them, and they in turn cause more inflammation, and that increases the porosity of these epithelial tissues. That means your respiratory tract is porous, your GI tract is porous, the skin, which is a main inflammatory organ, the immunological organ itself is porous in allergic individuals. So what happens is antigens enter through the skin, enter through the respiratory tract, enter through the GI tract, and they go and interact with your immune system. And this is the main thing we need to understand, that allergic individual has a porous skin, porous mucous membranes all over. And it is, if you look at it logistically, how much of our system is interacting with environment, it is huge. Skin is the largest organ, Every inch of skin is interacting with environment. Environment is full of noxious agents. Respiratory tract, if you look at the surface area of the respiratory tract, we know it is equal to tennis court. Imagine how much of our respiratory tract, and GI tract is another huge thing. So a huge surface area in each one of us is interacting with environment. So this is sort of an imaginary picture you have to have, that we are interacting, all of us, with a huge map of us interacting with the environment. And no wonder pollution, noxious agents, gases, pollens can interact with us all the time and cause both significant damage. And this is a classic, this is sort of a diagrammatic fashion. And this is not all of our graduates of our program are very familiar with this allergic reaction mechanism, where you get the initial exposure and the re-exposure. I don't want to get into this detail, but basically telling you The initial exposure causes sensitization. Sensitization means formation of IgE antibodies, which is hooked onto the mast cell and ready to attack when there is a re-exposure. And one of these blue arrows are showing you where our treatment modalities work. So we use a lot of steroids, antihistamines, anti-allergic drugs, a lot. Where does it work? It works at the tissue level. When a reaction has already taken place, mediators are released. And that is when these things work. And we think we are doing a great job because the patient is getting better. Actually, you are not doing a great job. You are not stopping anything. The reaction is still continuing. Actually, the reaction starts at the T cell level when it is telling the B cell to produce IgE through those interleukins. So the only modality that can actually influence the allergic mechanism is allergen immunotherapy, because that is the only intervention that will work on the T cell. And we need to know allergy is a T cell driven disease. It is driven by T lymphocytes. It is not IgE. It is not mast cell. It is a T lymphocytes that is driving the whole thing forward. And unless you address the T cell, your disease will never stop, in spite of the fact that you may be using inhaled steroids and antihistamines and whatever modalities you have 24/7, 365 for 10 years, 15 years, 20 years. It does not matter. The T cell is not stopped. The only modality that influences the T cell is allergen immunotherapy. And this is just telling you what a normal thing looks and what an allergic inflammation looks. There's a significant amount of tissue damage. So allergy is a T cell driven disease, and that is the main culprit. It is not IgE. So this is the basic defect I have told you. I'm sorry why it is running again, I'm not sure. Now, let's come to allergy skin testing. What are we doing with allergy skin testing? What we want to know with allergy skin testing is one basic fact. Is this patient sensitized, or is this patient not sensitized? That is the only question we have when we do skin testing. I told you already, sensitization means presence of IgE, specific IgE antibodies against that particular antigen hooked on to the mast cell, which is there. These mast cells are present on the skin, they are present in the mucous membrane, they are present in your respiratory tract, in your eyes and all that. But we use skin as an indirect organ. Patient will have allergic rhinitis where the nose is involved, allergic conjunctivitis where the eyes is involved, allergic asthma where the lungs are involved. But we do skin testing. Skin, which is may not be involved, but still, these mast cells which are have the IgE antibodies hooked onto their surface are also present in the skin. So we use skin as an indirect way of showing the presence or absence of the specific IgE. So skin testing is an in vivo assay of specific IgE antibodies. The only reason why we do it is for detecting or ruling out or ruling in sensitization. So it is an immunological test. It's not a clinical test. It is an immunological test. So it is used for diagnosis or to confirm your impression. It is also used for prognosis. It is extensively used in research. For diagnosis is once you have taken the history and you suspect, this child has allergies. I want to confirm it. And how do I do it? I want to demonstrate whether this child or individual has specific IgE antibodies against this particular antigen. And that is the use of skin testing using that particular antigen. You go ahead and break the surface of the skin by doing the small prick, and that particular antigen, specific antigen, enters through the dermis, through that hole, through that small nick that you cause in the stratum corneum, enters the dermis. That's where the mast cell is readily sitting there. If it has got the IgE, specific IgE antibodies hooked onto the surface of the mast cell, it immediately couples with that IgE molecule with that antigen, and then degranulation takes place. You get the histamine release. So it's an immediate reaction. You get the action of histamine as well as other mediators that are preformed like kinase, tryptase. You remember the triple response from your MBBS days. You get redness, swelling, warmth. That is what allergic reaction is. It occurs right away within a few minutes, within 2 minutes to 5 minutes to 10 minutes it occurs. Maximum, we take the measurement around 15 minutes. There is also a late phase in allergic reaction. You need to understand it is not just swelling of wheal and release of histamine. There is also a late phase which comes 6 to 8 hours later. The same area where the mast cells and all that, you also produce prostaglandins, you also produce leukotrienes. These are extremely potent pro-inflammatory mediators, and that causes they call different cells to the surface. There's an influx of eosinophils, lymphocytes, neutrophils. All these things are extremely strong inflammatory cells, and that causes the intense inflammation, long-standing inflammation, and that is exactly what you treat with inhaled steroids. You use inhaled steroid to treat the late inflammation, late reaction of the allergic reaction, a late phenomena of the allergic reaction. It is not the immediate. For immediate one, you use antihistamines. For late phase reaction, the only medication that works are steroids and anti-leukotrienes. And because they are caused by the late prostaglandins as well as leukotrienes, it's a late phase reaction. So late phase reaction is clinically extremely significant, and that is what we are treating with in all our patients is late phase reactions. So when you have late phase reactions where the inflammation is very, very strong, so when you have inflammation, there is tissue damage. I showed you that membrane of the nasal mucous membrane, huge amount of damage to the basement membrane, to the surface lining and all that. So when there is damaged mucous membrane, what happens is whenever there is damage, our body starts repairing. The minute you have a cut, you start also having a tissue repair. So that is what the damage and the repair occurs concurrently. So this causes irregular surface of the mast cell of the mucous membrane, and that is what we call as remodeling. It is like our roads. You are putting all this tar and redoing it. Within 2 weeks, there's a rainfall or something happens, and there are these potholes come on. And again, you do, and that is damage. Then you repair, damage, repair. And that is what remodeling is. And that is what we treat with inhaled steroids. You're treating that mucous membrane to reduce the damage, to keep it, to bring it as smooth as possible. But you are not completely stopping anything. The damage is still going on. You're just covering it up by the inhaled steroid anti-inflammatory action. Prognosis. When is skin test used for prognosis? It is used especially after allergen immunotherapy. It is also used in food allergy. In food allergy, 80% of the children get better with milk and eggs. They get better by the age they're like 5. But how do we know they are getting better? We do skin testing to find out. Initially, they may react significantly, like 8 to 10 millimeters, but gradually skin test actually starts going down, and that is called immunological regression. And when you are going up, it is called immunological progression. Same thing we do for allergic rhinitis asthma. When the allergic rhinitis is getting worse or clinical allergy is getting worse, if you do skin testing, you get bigger and bigger reaction. Once you start them on immunotherapy or with advancing age, when the allergic disease is going down, you do skin testing, the skin testing is becoming smaller and smaller because the specific IgE titers are going down. That is called immunological regression. So you have clinical progression, immunological progression, you have clinical regression and immunological regression. So these are all figured out by just doing skin testing. And it's a very rapid test. Within 15 minutes, it is quite a sensitive test. It's not as sensitive as specific IgE. But since you have a little bit less sensitive test, it is advantageous because you get less false positives. So it correlates with clinical picture extremely well. So it's a great screening test. Prick test, prick allergy test is a great screening test. It correlates about 80 to 85%. So there's a 15% chance of missing it. If you say like you have 50 of you, I do prick skin testing and 30 of you react. It means 30 of you have demonstrable specific IgE. That means you're sensitized. But we don't use the word allergic yet. We use you're sensitized. Once we take the history and you have symptoms and that correlates with your skin reactivity, then we call you allergic. So allergy is a clinical term. Sensitization is an immunological term. Atopy is a genetic term. I already told you what is a genetic defect. So he comes from an atopic family, but he looks fine. He has no symptoms, but his genes are already wired. That is called atopy. I did skin test on you. You showed positives. You showed wheal reaction within 15 minutes. You don't have any symptoms, but you are sensitized. That means immunologically, your system is active allergy-wise, but you don't have symptoms yet. But this person has not only sensitized, but he's also having sneezing, wheezing, rashes, and he's allergic. So allergic patient has to have symptoms. He has to have history. Sensitized patient does not have to have history, does not have to have symptoms. Atopic person does not have to have any of these, but genetically he's prone. He could be sensitized. Only when you do skin test, you will find out. So there are two types of skin tests, prick and intradermal, but we are going to stress a lot more on prick test because it's clinically relevant and it is sensitive enough for us to do the job. But intradermal testing, I'm not getting to it much now because it is done very selectively. It has its own risks and it is too sensitive. It is about 500 times more sensitive than prick test. So you get a lot of false positives, clinically irrelevant. So we go ahead and we only do prick testing on most of our patients when it is clinically significant and the prick test is negative, but clinically significant symptoms are there, then we do selectively intradermal testing. But intradermal testing done routinely for evaluation for drug allergy. So this is just showing you how a prick test is done. You will have a lot more information on it during the from probably other classes, but it's just telling you the wheal formation and the erythema formation that comes. It has got all these different shapes that are called pseudopods. So the normal reaction on the skin is done with saline. That is called negative control. How sensitive is your skin or what is the basal reactivity of the skin is found out by a negative, what we call as a negative control by saline. But I will go to that interpretation a little later. This is how a prick test looks and this is how an intradermal test looks. And these are all the different gadgets that will be used. This you will be probably getting some other class that they will go through these things in more detail. So basically all these gadgets are doing is just trying to make a small hole in your epidermis. How much allergy antigen fluid enters through that hole? How much actually needs? How much do you need? Is only 3 microliters, extremely small. So that is why you don't have to put the full drop when you do skin testing. Even putting a small nip of it as you are emptying the dropper and you just touch the skin, there's very, very small amount of the antigen material comes there. That is enough to do the skin testing. That is enough. The reason why I am mentioning this is skin test material can be terribly expensive, especially if you are using imported skin test material. 1 milliliter of skin test material on dust mite will cost you 2,500 rupees. By using the right technique, you can skin test successfully 100 to 120 patients. If you just use one drop, like what the usual instructions say, it will 1 cc, 1 ml will be done in 20 drops, 20 patients. That's all you can do. So you should be a little bit ingenious to use the cost-effective way. At the same time, you need to get whatever information you need. It's interesting to look at this slide. It is telling you that test sensitivity is highest in the upper back and the lower back in the back. Why? Because the mast cell concentration varies from area to area. It is quite high in the back of your on your back, upper back and lower back. Quite significantly high also in the arms and upper arm and forearm, but very, very few in the wrist area. So never do skin testing around wrist. Do not do any type of skin testing around wrist. Do not do any type of testing around large joints, about 1 inch or something, just to be on the safe side. But do the skin testing on the upper back or lower back, also on the upper arm and forearm, but not around the wrist. And this is what we call a tape transfer. After the skin test is done, you get the wheel and flare reaction. We go ahead and mark it with a colored pencil. Then with the cellophane tape, we transfer it onto the paper, and these will become a permanent record of your skin test. I have a little film that I'm going to show you now, one by Dr. Subramaniam, and I hope it works. Let's see.
When you make an appointment with an allergist, a skin test is a part of your evaluation and treatment. And skin tests are done for most of the allergens. Some of them don't have a standardized skin test. When you make an appointment, the staff will talk to you to allow at least 30 minutes to 45 minutes to come prepared for a skin test. They will go over all the medications that you're taking, because you should not be taking antihistamines for at least 7 days prior to a skin test. When you come in the office, after you talk to the physician, you will be asked to get into a gown, lay on your stomach. And those of you who cannot lay on the stomach, we can try to put the skin test on your thighs, sometimes on your arms, or even sometimes on your back, and give you a chair to put your head down. The skin is then prepared with alcohol so that any lotion or any creams that you may have should not interfere with the skin test. So all I'm going to do right now is wipe off the skin with alcohol, and that's it. Skin tests are performed with a special instrument. They look literally like a hairbrush. And what we do is we put 8 at a time to make it comfortable for the patient, and it does not hurt. I'm going to start with the first skin test.
Okay.
So I have done 8 of these. My staff and I always mark the skin just to make sure we know where the skin tests have been placed. Each of these are a group of allergens. There is a pediatric kit and there is an adult kit. What you're seeing is a very limited amount of allergens that we do in children. So the first set is dust mites, cat and dog. The second set on this panel is grasses and ragweed. The third set is tree pollens, and the last set is mold. You let the skin test stay on your skin for 15 minutes. If you're allergic, it itches, it does not hurt. And what you see is a little red mark like a mosquito bite. So we're going to wait for 15 minutes and we'll come back and show you positives and negatives. So in 15 minutes, the skin test is ready to read. And I want you to appreciate this entire panel. That's the tree pollen, which is negative on the patient's back. But we have snuck in some controls. This is histamine, another histamine, and another histamine. Histamines are controls placed to make sure that the patient has not taken an antihistamine. And when it's positive, it means this is a very good test. On this patient's back, we have dust mites, which are positive. And I want you to appreciate that it's red when compared to a negative test. So this patient is not allergic to dog and cat dander, not allergic to grass ragweed, not allergic to any tree pollens or mold. This patient is allergic to dust mites. Either we call this a positive or a negative reaction, or we measure. When you measure it, it helps me decide in 2 or 3 years if you have outgrown allergies. For example, the patient's dust mite today measures approximately 5 millimeters. And if I treat this patient 2 years from now, if it becomes 2 millimeters, I know that this patient has been treated. So I want you to appreciate a negative skin test as opposed to a positive skin test, which looks literally like a mosquito bite. At this point, the patient's batch is wiped off. The entire process took us 15 minutes. And to make the patient comfortable, cortisone cream is placed. The patient can go back to their daily routine. If this patient does not scratch her back, the itching will go away in about 30 minutes. So now that I have made the patient comfortable, I'm going to have her change. And then I will discuss with the patient what options she has to treat this dust mite allergy.
So that film just gave you an idea. So whenever you do skin testing, first thing we have to do is after 15 minutes, you first look at the controls. Actually, you look at the histamine control at 10 minutes because it peaks at 10 minutes. So look at the controls. A negative control, as that doctor was saying, is 0 to 3 millimeters. It indicates baseline reactivity of the skin. And positive control has to do.
Here at Signature really helps
How do I
me
do that?
recover fast and get to where I need to be in the next level playing
Sir, can you hear me, sir?
And
How do
I kind of went into the
Sir, can you
How do
hear me?
I shut it
and I
off?
had a problem with my knee. And
Yeah, sir, please stop that
I was over
YouTube
and
from your
so
side.
I went to the doctor
You have to-
and
Should I stop it?
went around that and like
Just
he
click on
told
the
me I don't
YouTube.
really what happened was my
What should I
tissue
do?
was stretched out.
YouTube you have to
And
open,
so
sir.
I had to get her kid either way if I wanted to play in college.
So click the Alt tab and stop that video, sir.
Basically, it showed me some
Oh, start the video?
like
Yeah.
stretching lines, things I could do
Yeah.
at home that I see. Bobby,
But it
it's
should
kinda
stop,
like-
is it not? I want to stop it.
You see when you come here. And he was actually like a professional trainer before this.
Just
so
accept
makes
that request, sir.
And it makes it kind of easier to think about what it would be like when I get back in the
What is
soccer.
this?
I'm going to Murray State to play in college. I actually believe in 8
Can I-
days.
can I get out and come back?
I got like almost a full
No, sir. Just give me a moment.
for there. So I highly recommend coming here as
Okay.
Sir, you try. Okay, no, it's
I don't know what it is, but
so you try stopping the PowerPoint and open it again.
yeah,
Close the PowerPoint and open it again.
yeah, sorry about that. I need to bring it back and
And now you can also stop that YouTube, sir.
pardon?
Hi.
I think YouTube link already open, so you have to stop that
I
YouTube.
will go and come back. It is safer because something else will come. Sorry about that. And is there are what we call as a prick on prick test, because the skin test can be a little tricky with foods. We go ahead and prick the food and then put it on the skin and then prick it, and that is called prick on prick test. That will be probably talked to you later on. The one thing I want you to appreciate is what is the difference between allergy skin testing that we always talk about and the immunocap or specific IgE test. Now, both are good tests. Immunocap is also a very good test, but there are certain issues with immunocap or specific IgE. Immunocap is a trade name actually. So we use the word specific IgE determination. So both are sensitive, but skin testing is a little less sensitive, so that the advantage is you get less false positives. Whereas specific IgE determination is extremely positive, extremely sensitive, which means you get a lot of false positives, which also translates to a situation that clinical correlation is poor. Many times it's very confusing. So it is not a good idea if some of your patients come to you and say, doctor, I want you to rule out allergy. One of my friend had this blood test. So can you please do that panel of blood test so that I can rule out allergy? And what that person had, his friend, was a specific IgE determination, a panel of tests run by a local lab. Never do that, because it will actually confuse the whole picture, both to the patient and to yourself, as well as unnecessary expense. You instead, what we suggest to you is you spend a few minutes, ask a little bit history, and you are better off doing a few skin tests, 4 or 5 skin tests in your office to figure out whether this person has any sensitization or not. Or you can do selective immunocap. Never do the panel. It will be very confusing. And skin test measures bound IgE. I mentioned to you that you are exposing the antigen to the bound mast cell, and that is what you are measuring. And that is more natural than the immunocap of the specific IgE, where you are measuring the circulating IgE or the free IgE, we call it. It is not natural. So there are definitely differences which actually makes it more preferable to do allergy skin testing than immunocap. So it is better I always tell my students is to teach skin testing to your colleagues, because it probably is a very simple thing. They can do a few skin tests. General pediatricians, general doctors can do a few skin tests rather than the specific IgE determination. That way, you are getting a better idea of what's going on. A specific IgE determination is good, very easy, but has some issues. And skin testing is definitely more affordable, and you can do much better referral by doing a few skin tests and a short history. So question is, I get a positive skin test. Does it mean allergy? A positive skin test or a positive specific IgE, does it mean allergy? No, it only means sensitization. It only means that specific IgE is present. If the skin test is positive, that means that specific IgE is bound to that mast cell. If the specific IgE test or the immunocap is positive, that means you have free specific IgE floating in your patient's blood. That is all it means. So you really have to take the history. Now, there are individuals whom you do skin test, it is positive, but they don't have a history at all. What you do with those type of patients is to follow them up. Follow them once a year. And what has been shown is persons who are sensitized, that means positive skin test, no history at all yet, follow them. They are 10 times more prone to develop allergy compared to persons who have negative skin tests or not sensitized. So sensitized individuals are at a higher risk, 10 times higher risk of developing allergy symptoms down the road. It could be 5 years, it could be 3 years, it could be 10 years. So they are 10 times at a risk of developing allergic disease than non-sensitized patients. So coming to testing of antigens, why should you test with a particular antigen? Why dust mite? Why cockroach? So this is something we need to know. So we know that asthma or allergic disease are all multifactorial disease. Asthma especially is multifactorial. Allergy is one of the causes of it. So I'm not getting into all the different factors. I just want you to appreciate allergy is one of the reasons why you can have asthma, that is allergic asthma. And the allergic asthma or asthma caused by antigens are most of the time antigens that are indoors. inhalants, if you take what type of inhalants causes asthma, is dust mite, cockroach, molds. Those are the three things that are asthmogenic. Pollens also cause asthma, but not as much as dust mite, cockroach, and molds. So these three antigens, dust mite, cockroach, and molds, are like alternaria, are the ones that you really have to pay a lot of attention to. So indoor antigens are the ones that cause more asthma than outdoor antigens. We are only talking about allergic asthma now. But asthma can be influenced by so many other things I mentioned to you, including so many of all these different irritants, tobacco smoke, diesel fumes, all that. We are not getting into that. So which antigens do we need to worry about? I would definitely worry about indoor antigens. The indoor antigens are dust mite, cockroach, alternaria or the mold, cat and dog, and rodents and mice. And occasionally we also have to look at certain type of outdoor pollens too. And molds are present both outdoor and indoor. So, question is, this child has asthma or this person has asthma, does he need skin testing? He does not have any history to suggest allergies, but it is very difficult for us to figure out allergic component by history alone in these patients. So, and also we know that there are 3 indoor antigens that can really cause asthma in these children where the allergic disease is progressive. So I want to know whether this child is at a risk of developing asthma. You know, he has not developed asthma yet. He's only having some upper airway symptoms now, and he has got a positive family history. But is he at a risk of developing asthma is the question. I would definitely do skin testing on that child for these 3 antigens for sure. That is dust mite, cockroach, alternaria. And you can also add 1 or 2 pollens. So 5 skin tests, 2 controls. So within about 10 skin tests will pick up 80% of the sensitization. That is, you don't have to do testing for 30, 40 antigens. 10 antigens will pick up 80% of sensitizations. Okay. So these 3 antigens are very, very important. What has been shown in the US is a huge number of asthma cases has been attributable to allergic reasons. Okay. And more than 80% of school-age children with asthma are sensitized to more than 1 antigen. More positive skin tests, more sensitization, more severe is the asthma. They seem to go together. And this slide is showing that if you test early and evaluate these patients early and institute immunotherapy early, you can actually reverse the problem, or you can control the problem a lot better because you are treating the T cell much earlier than waiting and waiting and waiting. So it is not a good idea to keep on saying, oh yeah, you will grow out of it and you will get better and all that. They won't. Now you see a patient with allergic rhinitis in your office and you treat them with inhaled steroids and antihistamines, they get better. But patient is happy. Now, are you happy? Are you supposed to be that happy? Actually, no, you should not be that happy. Patient is responsive, that's great. But I also want to know this patient is going to have 6 months from now, 1 year from now. Is this disease this patient has, is it progressive or not? Is he going to have immunological progression? Is he going to have clinical progression? Because those 2 things are not touched by the medicines I'm giving. So I want to evaluate them in addition to the fact that he is getting better. I still want to evaluate. So 6 months later, I will call the patient. I will do a few retesting and see what is the size of the dust mite, what is the size of the cockroach, what is the size of the mold and all that. And if I find that the size of the dust mite reaction is getting bigger and bigger, that means there's immunological progression. Then I also ask at every visit a few simple questions to the mom, or mom herself will tell you. Mom will say, my child is better, I'm happy. But if I miss 1 dose of medicine, he starts having symptoms. Or if he needs, before I used to give him 1 teaspoon, now I have to give him 1.5, 2 teaspoons to get better. Or she will say, before it would work within 2 hours, now it is taking 4 hours to show some effect at all. Now, another thing she will say, patient, my child is now having a little more. I'm happy, but he coughs a little bit more at night. And he also coughs when he is running. These are subtle things. These are what we call as clinical signs of progression. This you cannot find out by listening with a stethoscope. You cannot find out by doing spirometry or peak flows. You will find out only by patient interview. So this is a clinical impression. So this is called clinical progression, and we can supplement that by doing a few skin tests, by doing immunological progression. So these are subtle. So if it is a progressive allergic disease, you need to be concerned that he might be a candidate for allergen immunotherapy down the road. So one of the things, the major allergen in India is dust mite, and that's 80% of people are sensitized to it. And what this slide is showing is higher the dust mite antigen exposure, more the exposure to dust mite, more sensitization, and more sensitization, more morbidity. Now, cockroach is the next most common antigen, and cockroach antigen is present in its GI tract and also in the fecal matter. And the same thing with dust mite, it is in the fecal matter. And it is everybody's house has cockroach. Okay. So there is nothing like, I don't have cockroach in my house, nothing like that. And cockroach antigen is present, and it is present mostly in the kitchen as well as in the living area, and it's highly, highly antigenic. It's always a good idea to do skin test with cockroach because it's asthmogenic. Same thing with cat and dog. It is present, it is very, very sticky. And homes that have got pets have got allergen levels 100 times more than homes without. So this is something you need to be aware of. Mouse and mice are also antigen that you need to be aware of, because all these you may not see them, but they do urinate. The urine dries up, and the antigen is present in the urine, and that becomes airborne. And the pollens is something you need to know. It is outdoors, but it can be indoors too. But the advantage of the pollen is it is much bigger in size compared to the cat and the molds. So that is why most of the pollens get deposited in the upper airways. They get allergic rhinitis. Few pollens get into the lower airways, and that causes allergic asthma. And one of the things that you need to be aware is it's called episodic thunderstorm asthma, where due to thunderstorms, because of the high humidity, the pollens will absorb the water and they sort of burst, and that causes submicronic pollen fragments. And these are extremely small fragments of pollens that are inhaled, and it can cause havoc. In one of the major thunderstorm asthma occurred in Melbourne, but I forget the date, probably in around the 90s or early 2000, when around 1,000 people got hospitalized in one night because of this terrific asthma. And most of these patients had only allergic rhinitis or mild asthma. So thunderstorm is something you need to be aware of, because we get a lot of thunderstorms and we feel that, oh yeah, air is getting clean, but at the same time you need to be aware. But when it occurs in the summertime, it could cause thunderstorm asthma. And alternate, this is a mold that has been shown that it can cause significant asthma. And it is actually indoors and outdoors, and it is not uncommon, especially in India. When you enter people's houses, then you will see mold growth. When you see mold growth, that means there's a lot of molds there. And this was shown in New Orleans when mold spores went up and down. The emergency room visits and the asthma morbidity secondarily also went up along with the pollen, the mold spores. So it is telling you these 4 antigens, dust mite, cockroach, mold, especially animal danders, indoor antigens like rodents, and a few pollens can cause significant asthma. And that is the reason why we would like you to do skin testing for these particular 4 or 5 antigens on all asthmatics. So when you have immunotherapy, one of the things very, very important is proper patient selection, proper antigen selection, proper composition, proper administration. That is the only way immunotherapy works well. It does not work when you don't select the patients well. So who is the right patient for allergen immunotherapy? Is a young patient, young disease, young remodeling, and who has got early disease of onset of asthma. Even, like even 20, 25-year-old, 30-year-old is still young for us. But a 60-year-old having comorbid conditions, have a COPD with asthma, even with positive skin test, is not a good candidate for immunotherapy. A young patient with mild disease is the ideal patient for allergen immunotherapy. It does not help long-term severe disease. And we are at a stage that just like antibiotic, we know exactly what dose to give. We know exactly what dose to give. Even with antigens now, you need 20 micrograms per month. Pollens 50 micrograms per month. These are therapeutic doses what we administer with allergen immunotherapy. And this protease content has to be, you need to be aware of it so that you know how to mix these antigens. Like for example, if you are treating with dust mite, you can mix dust mite with pollens because both are low protease, but you can't mix high protease with low protease. You cannot mix molds with the dust because it will eat up the dust mite because of the protease content. It is proteolytic. A clinical scenario here, 25-year-old male, seasonal allergy, seasonal asthma, has got disease progression. He's a good candidate for immunotherapy because he's young, he's early disease, progressive disease, and you have the opportunity to treat him well. And this is a 60-year-old smoker, has asthma, COPD, still has positive skin test, but I would not treat him because he's not a candidate for allergen immunotherapy because his disease is much more complicated and it is much more severe and chronic. Allergen immunotherapy will not work in this patient because there's not good correlation also. So whenever you give allergen immunotherapy, a physician has to be there and you have to take enough proper precautions. And this is just a decision-making step for allergen immunotherapy. Say like initially you are getting an idea where even where first visit itself, with a strong history and with a few positive skin tests, this patient may have to probably will end up with immunotherapy. These are the patients you need to see more often. Do not start allergen immunotherapy in the first visit. You make the patient, the family aware of it, that you're thinking about it, and you probably could do it in this third visit or third or fourth visit. By that time, the patient has more confidence in you. The reason for that, allergen immunotherapy is a type of treatment which the patient has to take for 3 to 5 years. And the main reason why patients stop allergen immunotherapy is because of low compliance. The reason why they get low compliance is lack of education. You may be surprised to know that the drop-off rate for sublingual as well as subcutaneous runs almost 75 to 80% after 1 year of therapy. So studies have shown that if you start immunotherapy, you cannot just tell them to come after 6 months, see me next year, I have started your proper treatment, see me. Don't do that. See them every month for at least 5-6 months. Educate them, because educating the patient will increase the compliance from 20% to 60%. So educating, especially in the first year, is very, very important. After that, you can relax on education. And this is something everybody should have whenever you are doing any type of allergy testing or when you're on immunotherapy. But unfortunately, this is not available. EpiPen is terribly expensive. That's why we use this crude one where we pre-fill syringes. If Dr. Shambho can permit me, I will just show one film on it, then I'm going to stop it. Is it okay?
Yeah, sir, actually, we had one class by yesterday, last module by Dr. Balachandra, sir. So
I did not know.
He had demonstrated that.
Oh, okay, then I'll skip it.
Yes, sir.
I'll skip it. So emergency crash cart has to have a lot of things, but the most important thing is epinephrine. And this is just telling you more of a research thing where allergen immunotherapy will become revolutionary down the road. This slide is summary is you start allergen immunotherapy even before the onset of symptoms. This is something that is being worked at. So because sensitization occurs before the onset of symptoms, in this child will come and see you when he's 6-year-old and you start immunotherapy when he's 10-year-old. According to the research that is going on, you want to start it even before the onset of symptoms. This is called immunotherapy, early immunotherapy. This is something down the road. And also immunotherapy is undergoing changes with molecular immunotherapy. And this is something that will revolutionize the field. So I'm going to stop here. I know today is a big day for all of us, and this is what all of you are waiting for. So I'm going to stop here. Thank you very much for your patience.
Thank you, sir. Thank you very much for this elaborative lecture. And we are again thankful to you for giving us your valuable time, sir. So we will start panel discussion. But before
Can I
that,
stop the share? Can I stop share? Or
yes,
should I
yes,
keep?
yes.
Okay.
So I just want to first of all tell all the delegates who are there, please submit your post test now. I think already you get the post test in your mail. So you please submit your post test answers, and also I am requesting you all to submit any queries, any questions that are in your mind, so we can ask our panelist, our Vedantan sir. So with that, I want to start the panel discussion. Most probably there is one question. So with that, we will start. So Vedantan sir, one question from Dr. Anita Krishnan from Bangalore. Can we mix cat antigen with house dust mite and pollen in one vial of sleet?
Ideally, in India, that varies from where you are practicing. In US, it is not uncommon to have polysensitized persons, very, very common to have 20 very significant 20 sensitizations. But in India, you don't have that problem. So we can mix, as long as they are all low proteases. I think I remember all the three things are low protease. You can mix low protease. That is the maximum you go. Generally, we mix about 2 or 3 is perfectly fine. You can mix them. But if you want to add any high protease, you keep it separate. In the US, we mix 8 to 10 antigens. It is not ideal, but there's no way we can help it. But in India, you can do a much better job with immunotherapy. And Dr. Krishnan, yes, you can mix 3 antigens because they are all low protease. But
Okay.
if you want to, one word of caution there, one word of caution. Cat antigen, if you look at the stock solution, it is only, the way I remember, is it is much less concentrated than a dust mite. It has only around 40 micrograms or something like that per ml. Whereas dust mite has 100 to 150 micrograms. So you need a lot more cat antigen to that mix to be effective. So many times what we do is, although we can mix, we try to keep it separate because I can put a lot more cat antigen in the second mix so that it will be therapeutically more effective. That is the only reason I would keep it separate. You can mix, but I would do separate because of this particular reason.
Okay, thank you, sir. So actually today's session is on mostly on skin prick test. So may I request our delegates to please submit your questions regarding that. And yes, of course you can ask some other questions too. If we can have time, we will take those. So let's start today's panel discussion, and may I invite Dr. Krishna Mohan first. So sir, can you please explain some specific steps and precautions that are necessary to ensure accurate results from a skin prick test, particularly in the context of nasobronchial allergy we are telling about. Already sir has explained in his slides, but if you tell us about some key points on that issues.
Okay, thank you, Dr. Shambhu, for inviting me and giving me an opportunity to be part of this. So as you already told, sir has made it very comprehensive. He has told everything, but still I will add some more points. So to start with, documentation is very important when we are doing a skin prick test with the allergy. What we say, you can have an XPT recording sheet. You can improvise based upon your setup. You can improvise. It should include the age, sex, the allergen that you're using, the manufacturer, and the time when you're giving and the time when it is reported. And the next thing is that whether if you are doing it yourself or you are telling your technician to do that, a rapport is very important. You have to explain the procedure very well before starting the procedure. Clean the site either with spirit or 70% alcohol. And the important thing is that you have to use good quality allergens. And as Sir already told, the quantity of the drop used is very important. Only very less amount, 0.3 microliter will enter the dermis, irrespective of the size of droplet that you're using. So better do not waste the allergen. Use very small drop. And the lancet that we are using, that is also important. Make sure that you're using a small lancet, an allergy lancet with the tip is only 1 millimeter compared with the blood lancet, which is around 3 millimeter. So it will be a absolutely painless procedure. And probably we will be using the same lancet for different allergens. So make sure that after each prick, you're wiping with a wet swab. And after giving these pricks, you have to wait for 15 minutes. And after 15 minutes, you start reading. Before reading, you read, as Sir already told, you have to read the controls, the negative and positive controls before going to the further reading of this thing. And even before starting that, the medications on which the child is on is very important. You have to make sure that the child is off the medications, especially antihistamine, at least 7 days before the procedure. And you can start doing this. And distance between the different allergens should be minimum of 2 centimeters. So, and when you're interpreting, you have to read the controls first. And if positive skin testing, as already told, it is interpreted as more than or equal to 3 millimeter larger than the negative control. So this is what I have to say as a stepwise manner in which a skin prick test can be done. Anything more to add? You can.
Yeah, okay, sir. So as you were also mentioning about age is something which is very important factor. I think may I invite Dr. Shoibal Moitra, sir, regarding this age-related variability issues. So how does patient age can affect the interpretation of skin prick test results, especially when we are talking about two extremes of age groups, like a very young babies to very elderly patients. So what is your comment, sir?
Thank you, Shambhu, for inviting me in this program today. And means it's a beautifully a curated program, I must say. Okay. So as you have said that regarding the age variability on the skin test, we know that when we perform skin test, we have to take into account the controllable variables and the non-controllable variables, which can have an impact on the performance and interpretation of the skin test at a particular time. So age is an uncontrollable variable. So we say that the skin test reactivity decreases in elderly. That's after 60 years of age, there will be a marked decrease in the skin test reactivity. So that is one thing. And the histamine, and actually the wheel and flare response to the histamine, it is also pretty low in very infants and very young children. Okay. So these are the two things we have to take into consideration. But obviously, since it is in bioassay, and all these bioassays are stated with a positive and a negative control, so definitely we are actually comparing at a particular time the wheel and flare response with a positive and a negative controls. So that is important thing which helps us in identifying what is reactivity. But we have to understand that in very infants, that the histamine reactivity may not be large. It may be even less than 3 millimeters. Since in the mast cells, which actually the sentinel cells, they are numbers in young children, infants and all. They do not populate to that extent so that to bring about a large wheel and flare response. And it usually begins after 2 years in toddlers, and then after that it starts populating and have enough of skin barrier function, which develops after 2 years of age usually. That is how it has an impact.
Thank you, sir. So, sir, can you tell us about some cutoff, if it is there at all, when to do SPT skin prick test and when we should not do SPT skin prick test?
As I've said, Sambho, that SPT can be done in any age, but usually less than 2 years of age, it is very difficult to do because skin is very thin and the child may not be cooperative. And mostly we do it above 5 years of age. Okay. So that is the practical side of the doing a skin prick tests. And for the upper, there is usually no age limit for the upper age limit, but obviously in very elderly, the skin becomes so thin and friable also, that having a prick is difficult. You just end up going into the mucosa, so, and that might give rise to a false positive results in these patients. So that is how.
Yeah, thank you, sir. So as Moitro sir had been emphasizing on the importance of positive and negative control, so may I invite Dr. Gayatri Pandit, madam, regarding these controls when we are using skin prick test, what are the important issues we need to keep in our mind? How important are positive and negative controls in skin prick test? And what are the protocols for ensuring the overall efficiency of the skin prick test on these positive and negative controls?
Yeah. Thank you, Dr. Shoaibul, and wonderful class by Dr. Vedantan sir too. It was a good revision class for us too. The reading that or the final interpretation that we are going to give is going to depend on the negative and positive control values, because many a times we see a disparity, as in somebody reporting the allergy test as in plus and a 3+, 4+. But what we rely on is our negative control, which is actually indicates the patient's baseline reactivity, and 3 millimeter more than the baseline reactivity is what is called as a positive reaction. And the positive control, which is histamine, actually determines about interference of the test, if there are any drugs which are actually interfering with the test. Now let us see where are the situations where we might have a poor negative controls. The poor negative control is where a patient might react, we generally expect that the negative control is around 0 or at the maximum 1 millimeter, or at the maximum to maximum is 2 millimeter. So sometimes you might end up having a negative control itself as in 3 millimeter, 4 millimeter. So it's usually dermographism is a condition where we come across such high negative control, like people who have a very high baseline reactivity. So there you will have to read the test with a caution, or you may not even consider reading such test sometimes. So if your patient already has a dermographism, you have to see what causes a dermographism is a pressure. So you have to make sure that when you're doing a prick, you're not putting a pressure. It's actually just an epicutaneous lift that you do, and you don't do it with a pressure. So that's a caution that you will need to take when you're doing it in a dermographism. Poor positive control, which is your histamine, where it is not reacting up to 3 millimeter. The bare minimum reaction that you expect for your positive control will be 3 millimeter, where you are not having the reactions of a 3 millimeter. Could be because of the extremes of our age, where Dr. Saibal already mentioned, or patient is on any antihistamines, which antihistamines and the other drugs, which Dr. Krishnamohan and sir already told. The other thing is the topical drugs. Sometimes we might miss. We will ask about the oral drugs, but we might miss on asking the topical steroid applications for a 7-day trial, like in atopic dermatitis. Even the topical antihistamines up to 3 days, even that can interfere to certain extent. So that also which we will be, wanting to add on to. And sometimes even not as a negative control, but as in precautions, that one thing that I wanted to add to what Dr. Krishnamohan told is, in a hairy individuals, it is little difficult to take the reading. So I would usually prefer them to shave the hand a day before or something before they come for a test. The other important thing that we might get a negative control is if patient is on alternative medicine. So you will ask whether you have taken a citrazine, whether you have taken an antihistamines. Patients will say no. but patient would have been on some other alternative medications for a similar problem, which might have an antihistamine property. So that is also a condition where we might, end up having a poor negative control. So this is the precautions that I usually take for, to have a good positive and a good negative control.
Thank you very much, madam. Thank you. So as we are talking about now the allergen extracts, may I now invite Dr. Shomna Nagarajan, madam. So actually, do we need to use the same allergen extracts as used during the skin prick test while doing the allergen immunotherapy? And what are the important considerations on that perspective too? Madam?
You're muted, madam, muted.
Hello, am I audible?
Yes, 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 madam.
Yes.
Yeah, thank you, Dr. Shambhu, for inviting me for this very important meeting. And it's always a pleasure to listen to sir. So, to your question regarding should we be using the same allergen extracts as we use for skin prick test for immunotherapy, that's a very common question we encounter, because there is paucity of standardized allergen extracts in India, but the allergen extracts what we use for skin prick test here also we do get good clinical correlation with the history. So it is always better to use the same allergen extracts as we are using for the skin prick test for the immunotherapy, because that is reflection of the allergen extract in that particular allergens. Say if we have done for one dust mites from one standardized extract, it is better to start immunotherapy with the same allergen extract for the immunotherapy. For pollen, if we have used a certain allergen extract, it is important to use the same allergen extract because there may be variability in between the allergen extracts. So it is always advisable to use the same allergen extracts which we use for skin prick test.
Yeah, so thank you, madam. Thank you. So again, I'm coming back to Professor Vedantan, sir. There is one question asked by Dr. Nikita Rasguru from Ahmedabad. She is asking that maximum numbers of allergens we should test in one setting, and can we do food and aero allergens in same setting? So, yeah, so sir, can you please?
Sir, please unmute, sir. Please unmute.
Okay, you can hear me now.
Yes,
The number of allergens, there is nothing like so much number. The number depends on the history. Okay. So if somebody has classical allergic history occurring like throughout the year or 3/4 of the year, inhalant allergy symptoms, then if you want to do full panel, we have different panels. If I want to rule out allergies, the person says, I don't want to go through immunotherapy. I just want to know whether I have allergy or not. I just want to have some test where I want to know whether I am sensitized or not, or if I'm allergic. We have what we call as a pediatric screen panel and an adult screen panel. A pediatric will be about 10 skin tests, which includes the 2 controls. Adult will be 15 skin tests, where you can check. So 10 to 15 will give you a pretty good idea whether the person has some sensitization or not. And these are major antigens. When I say major antigens, more than 50% of people who have sensitized will react. So these are common major antigens. Now, if somebody is really wants to, has long-standing significant history, and you are also considering maybe immunotherapy for this patient, and the patient also wants to know, please do a thorough checkup for me and all that, then you probably may end up testing. The maximum I have seen here around 35 antigens. That is how many antigens that we use at CMC and many other training programs. That is the maximum they use for inhalants. Now, coming to foods. Can you mix food antigens for testing when you do inhalants? Yes, you can. That's not a problem. But food antigens, there is nothing like a panel. It all depends upon the history. And, what you could do is do not crowd all these tests in one arm. Okay. Try to, we usually use maybe 8 antigens on the forearm, another 6 or 8 on the upper arm. So about 28 antigens to 30 antigens you can use using both upper and lower arms. But if you can manage, you can do all of it on the back. So to keep it simple, depending upon the convenience of the patient, he's from the same town where the clinic is, you can do all of it. You can do 2 settings. If he's coming 200 miles away, you may have to do it in 1 setting. So it depends.
Yeah. So thank you, sir. So I think there is the one common misconception amongst all of us that sometimes the patient will come to us, and also we refer for allergy testing. We go for multiple allergen testing, skin prick test for 64 allergens, 90 allergens, like that. I think sir had clearly mentioned we should do skin prick test after taking proper history taking. And it is not like that we have to go through all those 64, 90 allergens. That will not ultimately help our patient, but may cause some problem later because of some false positive results. Also, there are lots of controversies on food allergy. Sir has mentioned clearly about that we need to take a proper history first, then we need to go for the food allergy testing. May I ask a little bit on these issues again?
Can I add one thing on your statement? Can I add one statement?
Please, sir, please.
Mention. The more tests you do, more confused you are.
Yes, definitely, sir. So there are many myths surrounding food allergy. So now may I invite again Dr. Gayatri Pandit, madam. So when we talk about food allergens in skin prick test, what are the special considerations when testing for food allergen in a skin prick test? What is your opinion, madam?
Gayatri, you're muted.
Okay, so I said you should have asked this to Dr. Soumya, because I practice predominant, since I come from an ENT background, I predominantly practice respiratory allergies. Okay, but what I can definitely tell you is that frequently there is demand from parents to, because assumption is that the banana is causing the problem, curd is causing a problem. So assumption is that the food allergens are causing the respiratory problem. Okay, but we know that, it is predominantly only from the aero allergens. So I do test for a food allergens only for a selected, which sometimes the patient is demanding, to prove that it has a negative predictive value. Okay, so because I test that and tell them that it is negative, and tell them that food allergens has a more negative predictive value than the positive predictive value. So if you get negative, we are pretty sure that it is negative. If it comes positive, it may be still be a reaction of a 4 millimeter. You are still not in a position to tell that you are sensitized to that. So I do food allergy testing only in such situations. So a proper food allergy patients, I refer it to Soumya, and I think Soumya can take a question.
Yeah. So may I ask to again Dr. Soumya, madam, to kindly enlighten us about this?
So as sir was telling, we have no a limitation of there is no restriction of testing the food allergens when we are doing an inhalant. But again, it must be guided with a very good clinical history. In pediatrics, at least we get a lot of food restriction patients, mother, family, everybody would have restricted all the foods, and nutritionally it would be affecting the child. So I think that has an effect on the immunological status of the child as well. So only upon a good clinical history, we would try to do a specific food allergy testing, unless it is very clinically correlative. Even in true food allergies, if the history is very strongly positive, but if there are multiple food allergens, I think the top 8 food allergens we usually should be testing. If we have any doubt, if it is in the mixture of those include milk, egg, wheat, soya, peanut, tree nuts. Lower down the list, shellfish and fish.
Okay. Thank you. So, at the same context, sir has also mentioned about the importance of pre-contact test. So, can you please enlighten us about that also a little bit?
So, sir has nicely covered in his lecture. But prick test, we try to do it when there is absence of standardized allergen extract for testing for the same. And if the clinical suspicion is very high, we use the fresh foods of the food in question, and we try to do it. But it's also important, as sir always highlights, that it is important to have a control. A patient who does not have the same suspected allergy to that particular food, so that we know that we have a very good control, and we are able to test on a control as on the patient. So very commonly we do it for some of the fruits or vegetables, sometimes where the food extract is not available, the allergen extract for testing, sir.
Thank you, madam. So may I now invite Professor Moitro, sir. So when we talk about comparative analysis, Professor Vedantan sir had also mentioned the difference between SPT and specific IgE testing. So what is your thought on that, and how you address this matter on skin prick test compared to serum specific IgE testing in terms of categorically the sensitivity and specificity for detecting nasobronchial allergies? Sir, please.
Nambu, there's an interesting thing. I often, when I think about it, I say, yes, means it is there. It's not very much into the context, but it paves the way into it. You know, this allergy terminology, it was coined long back by one Paperquet. Okay. So when he coined this term allergy, what he meant by allergy? Okay. What he meant by allergy is only altered reactivity of the body to any foreign substance. That's all what he meant. So that is what he called his allergy. Now he said that this altered reactivity can be beneficial, which he called immunity, or it could be harmful, which he called hypersensitivity. So that was his nomenclature of the allergy. Now, over the period of years, the allergy became equated with the hypersensitivity. And we say that allergy is something which is harmful because it is causing disease, it is causing some pathology. So it is basically what we call is an harmful thing. So anything which is harmful is a disease. Okay. So that is what we have in our mind. So that is not only us, which we have in our mind, but it is being percolated into the mind of each and everyone. Whenever you say of allergy, it is not something which is good. It is something which is bad. So that means bad means it's a disease. Okay. Now to have a disease, you need a test. Okay. So for the test is that now once this IgE came and all, we started to have the specific IgE measurements. Before that, we had the skin test measurements. And this started to get equated with a disease which was misappropriately called allergy. So it's not that this test means allergy. Now we know it very well, and we harp on it repeatedly. And sir has said it very strongly, and that these tests are merely sensitization tests because they only detect IgE, whether it is free in the blood or it is bound to a mast cell. So when we are doing this test and we are equating this with a disease, which also we have a wrong concept called allergy, all the confusion crops in. And so these tests are wrongly interpreted, they're wrongly advised, and they are wrongly used for the treatment purpose, and not in the proper light in which it should have been used. This is in a way which we call an original sin of misinterpreting the allergy, which was coined by Paperquet, and we are paying for the sin. So if we have to say this is the blood test and then the skin prick test, like this lecture started very clearly said, that when we do this specific IgE tests, these are very sensitive tests because they can detect even minute amount of the specific IgE in the blood. Sensitivity in the tune of, say, the 98%. Okay. But when we compare the specificity, it is not that high. Many studies have shown specificity to be around in the range of the 70% or so like that. Though the immunocap people, they claim that is Fadia, they have a sensitivity of 89%, whatever it is. But for the inhalant allergens, when we talk about it, ranges in that in that bracket. But on the other hand, if we talk about the skin prick tests for the inhalant allergens, its sensitivity may not be as high as the specific IgE, in the tune of it is around 95%, but it has a fairly good amount of specificity, around this 70 to 90% is a specificity. So around 80%, 80-85% is specificity. So if we do a skin prick test, which can be used as a screening test, you can have a lot of false positives. So which is less likely to be in the skin test. But what do we do to increase the positive predictive value or the sensitivity specificity of this particular test is to have a very good pre-test probability of having a disease which can be detected by this test. So that means this test has to be supported, has to be their significance has to be increased by a high pre-test probability. How do we get the high pre-test probability? That is by a proper history, which will guide us what to test and what not to test. And not only that, you should have a high post-test probability also, which is because we again have to go back to the history and again have to correlate to what positivity we have found, whether it is correlating with the patient's history, whether that allergen is there in the patient's environment or not. And then we come with the diagnosis. So you see that the original problem with the term allergy, the confusion, has led on to sway for this test to be interpreted in this light. So this is really difficult for any naive or any novice or any who has been trained in the traditional medicine, in what we have been trained in a biochemistry, in a pathology, to understand this very important concept, because this is there right from the beginning. So anyway, so sir has very clearly said skin prick test is though a little less sensitive than the specific IgE, but it is more specific. So otherwise, the correlation is more or less comparable. The majority of the allergens, we say for the insect venom allergens, is very much comparable. Okay, but in the context of the inhalant allergens, this is a thing which is there.
Thank you, sir. Thank you very much.
Dr. Shambhu, can I make one point?
Yes, yes, please.
Yeah, to add on that, sir has told about the in vitro test, but now of late, an unhealthy trend which I am seeing around the place I am practicing is that many doctors are prescribing the CRDs, and component resolved diagnosis, as well as the Alex test and all, and they're costing around 15,000 per patient. So just for finding out an allergen, many doctors are, that is a unethical thing. What is your opinion? I don't know. Others, because CRD is having a specific indication, not for simply diagnosing allergy. So
Yeah.
the companies are also promoting that, and that is what is happening.
I think one of the question also rise in our by one of the delegates, that is Dr. Trupti Gadhavi from Bhuj. She had asked that, sir, can you please enlighten us about CRD allergy panel testing and how reliable it is when strongly positive. So I am just inviting our esteemed panelists to have their comment on this CRD during this allergy panel testing. And as Dr. Mohan has rightly mentioned, there is a tendency now to promote the component resolved diagnostic amongst us, and without having any history. We are many times we are seeing that the patients were given this test, and there is a huge amount of money expenditure already done with this type of CRD testing. So what is your thought? May I ask our respected panelists to give their views on this? May I start with Gayatri, madam, please?
Oh, sorry. Go ahead, Dr. Gayatri.
Sir, you want to comment first?
Very short. CRD, as Dr. Krishnamohan says, very, very expensive. It is not uncommon in India. Whenever new thing comes, everybody jumps on it. And there are people who are willing to pay because the more you pay, they think it's a better test. So that is the problem. So this test should be confined to super specialist who is already confused. Okay. So this should not be done by any general thing. It's not a screening test. When I am confused, I do CRD. I will never do it for screening. I am not sure about certain thing, say like about say like insect venoms. You know, there is cross reactivity, and the reason that there is cross reactivity when you do immunocap is because of carbohydrate content. You will react. That is the reason why. But in CRD, you don't have the carbohydrate content at all. That is eliminated. You're only looking at the proteins. So it is a much, very, very superior type of testing, but should be confined only for very specialized conditions. It's like what Dr. Krishnamohan was saying. It is analogous to killing a fly with a revolver rather than a little flap. You know, so it's super kill, you know, and you do a lot of damage, not to the patient, to the whole community by just misusing such powerful tests, which are good to have. Even in the US, it is used for research purposes and very selectively. Okay. So it is not a thing that should be used by generalists to rule out allergies. Totally unethical.
Thank you,
I
sir.
completely agree with what sir has mentioned already. The specific indications where we would be going for an CRD are, where especially in food allergy patients for risk stratification of anaphylaxis. Like, we will, if the patient is sensitized to particular protein of a food, like in an egg or something, then the risk of anaphylaxis will be more. So in such special cases, some, in wheat-induced the exercise induced wheat anaphylaxis, one of the common conditions. So where you have an increase in omega this thing of an wheat protein. So only in such situations where you have some basic level of an informations from your history or SPT or an in vitro, and then you want to do a further refining of that. So that is when you are doing so CRD, and definitely not as a screening test and not routinely to be ordered by non-allergy practitioners at all, because that is where the promotion is going. So the promotion is going for more for the people who are not doing an SPT. Like, the promotion is going more towards an physicians, where like the way you write any X-rays or a CT scan, it is being written and sent. And there is so much involved in the interpretation of the CRDs also. It's not so easy to interpret. So there is so much involved in the interpretation. So that all requires specifically a training. So you can't just order like any other test how people are ordering. And also in vitro test, what Dr. Saibal specifically mentioned on sensitivity and specificity are more on when it comes to an immunocap studies. But with ELISA, the sensitivity specificities are much more lower. So we also see that there are many more other in vitro tests also which are being performed at ELISA level also. So sir, Dr. Moitra, so I think the sensitivity is much lower when it comes to the ELISA technique of an in vitro. What would you comment on that, sir?
Actually, Dr. Gayatri, the problem with the ELISA is somewhere else. Okay, the problem with the ELISA is, see, the ELISA is also detecting a specific IgE to a particular allergen, and the immunocap is also detecting a specific IgE to a particular allergen. Okay. Now, see, the immunocap is a fully automated closed system where there is particularly zero means involvement of a human error, which is basically is going to crop in other methods where there is too much of the human involvement. So what happens is that you order an immunocap, and you can be rest assured that whosoever lab who is doing an immunocap, which is a WHO standard, that the results what they have given is of good quality, so that you can be rest assured of. So what the difficulty what happens in ELISA is that ELISA is a very tedious process, a tedious time consuming process, because for the ELISA, we need to run the entire set of the allergen, a standard curve. We need to formulate a standard curve of our own, and that standard curve, it depends upon what is the concentration of the allergen being used, the quality of the allergen being used, and also various other factors into it. So that means that each and every individual lab has to have its own standard curve with which they are going to compare the result of the patient's sample, and then they are going to give the results. So this is not at all comparable between lab to lab. So there is a high lab to lab variability in the ELISA. ELISA is only good in your own setup. If you are doing it, like you're means the biochemist is doing it, you are running the standard curve, you are correlating with the patient's history, and you say that your standard curve correlates very much well with the patient's history, and it goes and you ensure about the quality. So that is very difficult to ascertain, because otherwise we are a clinician, we cannot do it. So that's why the ELISA is taking a backseat. But like when we started doing the specific IgE, means we had all these allergens for which we had no immunocap, because there were no allergens for that, or the indigenous allergens. Okay. So we have to do an ELISA because we have to prepare our own standard curve every morning, run it, prepare it, and then do a batch-to-batch analysis of the patient sample and give the results. It used to take a fairly around 5 to 6 hours every day for the biochemist to do it. But the results were good because the results were not that bad. But once this immunocap came, and once we started having more and more of the allergens in the immunocap panel, the use of the ELISA started to go low. So that is the thing. Okay. But yes, obviously, I must say that the results that we have, the standard literature that we have, it is based on the immunocap because that is a standard method. Okay, so even the chemiluminescence is not a standard method. Okay, the Euroline, they say, is a standard by some, but and that is but what we say is what we have in our hand is immunocap. Okay, so maybe with the batch-to-batch variability, the quality of the test will reduce the sensitivity and specificity for the ELISA in many of the cases. You are right, I must say that.
Yeah, thank you, sir. So, may I just ask Soumya madam, because we are talking about CRD, if a patient is having 3 or 4 episodes of anaphylaxis and maybe the cause is something food. So, if in that subset, the patient if want to do the skin prick test, that is not possible because we know that 4 to 6 weeks gap is required after 1 episode of anaphylaxis. So on that background, how you place CRD, and as now we have CRD, do not have a specific that is allergen specific CRDs are not available. So after taking history, madam, what are your views on that CRD testing in this type of patient?
I agree with my other co-panelists that CRD is being very misused. But in the background that we have had anaphylaxis where the probability of cause is not known, and we are unable to do, as you rightly said, in the 4 weeks. And we have to know, I think that is one of the specific indications where I may use a CRD for knowing the probable allergen. Probably in the near future, we may have specific components of testing in the CRD for the few commoner food allergens. But unfortunately, right now, we don't have that. It may be a panel of the whole 300 plus allergens. We are forced to do it because of the paucity of the testing allergens. But idiopathic anaphylaxis is one thing where I feel if the food is a lot of the suspected trigger. And I routinely use CRD also in prognostication of food allergy. And if I have to choose a patient for oral immunotherapy, where I know that the child would not outgrow that particular food allergen. If it is a heat-resistant allergen and the probability of outgrowing or reintroduction back into the food is a little unlikely, and the chance of anaphylaxis is quite high. I think that is one indication again which helps us in knowing who would benefit to proceed for oral immunotherapy. Otherwise, I think the limitations of CRD is quite very specific. The other thing I would like to add on is in the oral allergy syndrome. Probability if there is a lot of food restriction where we know that and we are not able to find the answers on the skin prick test or in vitro testing, that may be another specific indication where I may use CRD.
Thank you, madam. Thank you. So now may I ask Dr. Mohan regarding allergen selection while doing the immunotherapy. So
One thing I add for the CRD.
yes.
Okay, like as we all know, we all understand, we acknowledge this very well, that CRD is a futuristic tool. It has a very big role in the food allergy, and as Dr. Soumya has just stated, and also to certain extent that to find out the true sensitization in the insect venom allergy if we are proposing want to go in for an allergen immunotherapy. But if you see that how this CRD, basically we are detecting the IgE only, but the granularity of the IgE is further increased or further enhanced by doing a CRD. Okay, so it's just like you are seeing anything under a microscope. So you increase the granularity by utilizing an electron microscope, and you for mostly for few of the reasons. So do you have electron microscope in all the labs? And do we inadvertently or indiscriminately we use the electron microscopy? We do not. It's the same way. The CRD is an electron microscope as of now of that of an IgE detection. It goes into much more granularity. We are detecting the specific IgE against particular epitopes. Okay. So why do we need to go into such granularity, and what are its implications in the clinical practice? Recently, there's a very good molecular allergology guidebook by the Yaki. And I think like if anyone who wants to do a CRD or write a CRD, if they go through that molecular allergology guidebook, then he or she will at least stop writing the CRD, because the development of the CRD is based upon the major and the minor epitopes for a particular community. Okay, which are major epitopes in the community, which are the minor epitopes. We have the naive or the natural epitopes. We have the recombinant and allergens against which is the specific IG is measured. So its role is very limited. Okay, and to take very fine decisions, especially its role is more in the food allergies and also in very other. So it is not to be used indiscriminately, because you just write a CRD, a patient ends up paying 15,000 rupees and you get a big report. Then you don't understand what to do about this report. So this is a tool which will which will just get a bad name. Of late, I've been seeing that this is the Yaki in Europe and all, they have started promoting a newer modality of the diagnosis, which they call the precision allergy medicine diagnostics, PAMD. Now, the PAMD, which they are going to promote more for the precision medicine, that CRD has a big role. They understand, they do the CRD, you took the blood, do the CRD, and you say that what is clinically relevant and what is not. But how was this developed? This was developed on a large scale, multicentric birth cohort and other studies from the Europe and the US, which has paved the way for the development of the PMD where the CRD can be used. In India, we are still not at that stage. We do not have any birth cohort for the allergy. We do not have any large scale studies about the epitopes, major epitopes, minor epitopes in our country. We do not have that. So the stage is not set yet to use CRD in the clinical practice for all. But as Dr. Soumya said, again, the same thing. In few clinical decision making, especially related to food allergy, if you want to go in for a peanut immunotherapy and things like that, you can use the CRD. It should not be used like that now.
Thank you, sir. So as we are running running short of time, so we need to go through some more questions asked by our delegates So may I ask now, Dr. Mohan, how much is the risk of anaphylaxis in skin prick test? Dr. Gaurav Rajeshwar Dubey from Amravati had asked this. So can you please address this question, sir?
Yeah, the risk of anaphylaxis or any life-threatening event happening after skin prick test is very, very less. The exact statistics I don't remember, but I have listened to Vedantan sir class regarding that. It is just like your risk of dying after getting a lightning strike. So it is around what percentage of Vedantan sir? What was the exact percentage? I forgot.
Risk of anaphylaxis with prick test is very, very rare. I don't know the exact figure, maybe 1 in 10 million something, but risk of systemic reaction is there. I have seen people can have extensive acute urticaria, that is there. But coming to intradermal, yes, you can have anaphylaxis with intradermal skin testing. People even have died because of that. So that is one of those things we need to be aware. But prick testing is something very safe. But my take on it is, somebody says, I took this peanut, in 5 minutes, I had throat swelling, I had broke out with hives, and I felt like I was woozy out. You don't need to go and prove it and do prick test. Like, let me do test on you and see what happens. You are going to just provoke another reaction. If you really want to confirm it, do a specific IG, cap on it. It will be very strongly positive. It's a good test. Okay. And so do not do prick test just because you want to prove a point. So there is a risk benefit ratio. You need to use some common sense there. If somebody is giving you an answer, giving you the diagnosis, you don't want to double check it. As we know, diagnosis of allergy is not with any test, including CRV. It depends on history. That is it. So unless you do history well, do not even think about any of these tests. So if a history is giving you a very strong possibility, you don't need any of these tests.
Thank you, sir. So again, so I think that there is one question asked by Dr. Jemmy from Itanagar. I think that already we had discussed this. Why skin prick test is not recommended in chronic spontaneous urticaria? So again, may I invite Gayatri Madam to say 1 line or 2 line about that? Why it is not recommended?
One thing is the chronic spontaneous urticaria is not IG mediated. Where are you doing? Skin prick allergy test is predominantly in an IG mediated disorder that you are wanting to do that, right? So it is not an IG mediated disorder, and that's why the skin prick allergy test may not have a huge role. But having said that, many times chronic spontaneous urticaria also might have some other atopic conditions and then coexisting. The patients might also have an allergic rhinitis or an allergic asthma. So in that set of patients that we might do chronic spontaneous urticaria. I remember sir telling that though the textbook description is that, we don't practice any skin prick allergy test in chronic spontaneous urticaria. In US, they do a screening test for chronic spontaneous urticaria, and especially they have found that the dust mite being one of the correlations even in chronic spontaneous urticaria.
Right. Dust mite seems to be a definite correlation, and it could be one of the factors that we need to, because dust mite is not just mite. Dust mite, if you are sensitive, it is also in your food too. So you could have dust mite, relative of dust mite in your food also. That could also be contributing to this issue. But generally, chronic spontaneous urticaria, 40% is autoimmunity, 60% unknown. But again, go back to the history. But if, say, like somebody does a few prick tests, say a screening test for inhalants, there's nothing wrong in it. It is not malpractice. There's a possibility some of these factors could be playing a role. So, but it is not a major factor.
Yeah, and one thing.
Sorry. Yeah.
So go ahead, sir.
We do autologous serum skin test for urticaria. Again, is a little controversial, but it gives you an idea whether autoimmunity is involved or not. So in that way, it is more useful.
You
Yeah.
have to be careful in doing a food allergy testing in chronic spontaneous urticaria, because first of all, patient is confused about many foods and they would have eliminated from the diet. And in spontaneous urticaria, when you are doing, because they might have little high baseline skin reactivity, you end up having 4 mm reactions or a borderline reactions for many, and then you are not in a position, you are more confused what to tell to patient. So you need to be little careful in doing food allergy testing for spontaneous urticarias.
Generally, thank you, Dr. Gayatri. The workup for chronic urticaria includes CBC, CRP,
TP.
thyroid antibodies, that type of thing, not skin testing. If you can demonstrate autoimmunity and also therapeutic trial on antihistamines, high doses, you don't need to worry about allergy skin testing.
True, sir. True. So once again, thank you for this. We need to finish it because it is already 12
Yeah, we need
past.
to.
And one question still we'll take. I think that is last. This is the last question we'll take. Then after that, we'll not take any more question. Okay, there is two questions. So Dr. Anita Krishnan from Bangalore, she is asking that since milk and citrus have a higher histamine load, should we advise to go easy on them in spite of negative skin prick test for the same?
What is it? What is the question? First, in initial part, I missed.
First, she is mentioning that milk and citrus fruits, they are having higher histamine load. I think this information need to be re-evaluated. But at the same time, may I ask to Dr. Soumya Madam to respond this question, please? Madam, you have to unmute. No, we cannot hear you, madam.
Am I audible now?
Yes, yes.
Yes.
So very commonly we get this question asked whether milk has to be stopped or citrus fruits have to be stopped. I think as practicing allergists, we must emphasize that it is, though it is histamine rich food, it is not IgE mediated. And I think we must discourage the practice of stopping that particular citrus fruits or milk being causing more congestion in the background, that it may be causing more nasobronchial allergies in that context. So usually we discourage that practice of not to give milk or citrus fruits, contrary to the belief that it may cause more allergies.
Milk is having a high histamine content. I'm not sure about it. Are you sure about it?
Which
I've
one?
heard about banana having histamine content. Milk having a high histamine content.
Histamine containing foods. One of the things is cheese, sauerkraut, they call it, as well as sour cream and yogurt sometimes. And also it can, alcohol is also a non-specific releaser of histamine. There is no IgE involved. It can definitely cause histamine, just like any histamine can cause itching, and sometimes it can do it. So yes, it is possible, but it is not an allergy. It is a non-specific release of histamine due to these foods containing, or certain foods can release it. It's like dried fruits, dry fruits. And they can also release histamine. It's a non-specific release. You see, what you need to know, mast cell activity, which is reflected by histamine release, it does not have to be allergy. Mast cell can be activated by many factors: physical factor, chemical factor, nothing to do with IgE. We talk about IgE because we are associated with allergy. But mast cell activation syndrome is a separate clinical problem. It can be activated by many factors, and these come under that. Okay, it can cause same.
Yeah, so sir, the bottom line is then we should not tell our patient to stop histamine-rich foods like dried fruits or avocados or some fermented foods, specifically not meat, but fermented dairy products like yogurt.
Yes.
That can be contain high histamine, but we should not tell our patient like that. You should stop this type of food.
No, it is not like containing. It can make your mast cell release it. It can actually make it release it. In those people, yeah, you have to avoid it or take some antihistamines on though. Suppose say like somebody is taking that food like a basic food, like a yogurt type of thing, you may have to have them take some antihistamines to do. But dried fruits, you don't have to take it every day. You just take some other type of.
Yeah,
So,
depending on the history, then only we can tell them. So most
Exactly.
important is
Depending on the
important is history.
Dr. Saibal has something to say.
yes,
Sir, please, sir.
actually, Shambho, like when we are talking in the context of the skin prick tests, so this is a very specific pathway by which we are allowing the mast cells in the skin to degranulate. And that very specific pathway needs an intermediate. What is that intermediate? The intermediate is a specific IgE. So the specific IgE has to be there, which is bound to a high affinity Ig receptor on the mast cells. And on top of that, the allergen sits and cross-links and causes mast cell degranulation. This is what we are testing in the skin prick test. Mast cells are ubiquitous. They're present all over the body, mainly where the body is in contact with the environment, like the skin, that is the mucosal surfaces, GI tract, respiratory tract, all where. So it does not depend like whether we are taking the histamine containing food, we are taking this, it has no impact on the skin prick test. So because the skin prick test, we are detecting only by a specific pathway of degranulating the mast cell. As Sir was saying that mast cell can be degranulated by numerous pathways. Mast cells, the sentinel cells, they're actually the guards, they are the guardians of our body, okay? So they will just react to anything which they see is, and they feel it's not right. They through multiple receptors on its surface, in the cytoplasm, in the nucleus, it could be anything. But we are bothered about only IgE-mediated disease, which we diagnose by a skin prick test. So we do not say that stop these foods before going for a skin prick test. It has no implications on the skin prick test result.
Thank you.
Because it can be released with hot shower.
Yes, it can be anything, any physical, chemical, anything it can get released.
It is non-specific.
Yes.
So thank you, sir, again. Thank you, madams. So last question, Dr. Sonia Johari from Thane. She's asking that what is the association between vitamin D and allergy asthma? So may I ask Dr. Vedantan sir to have that?
I don't know. Dr. Saibal.
See, actually, there was
Some data.
Yeah, there was a very interesting paper in Europe. The interesting paper was that means as you increase upon the latitudes, okay, the allergy increases. Okay, because the areas in the Mediterranean region where in the lower latitudes where there's a lot of sunlight and all, the allergic diseases incidence prevalence is lesser than as you move up the latitudes in Europe, in the northern Europe, and so okay. And they related it. This is a very interesting paper. Okay, and with this, the concept of vitamin D came, and they correlated it with the sunlight exposure, leading to the vitamin D. Okay, so now we have seen. See, the low vitamin D is now it has become somewhat of a pandemic. Anybody you test vitamin D, it will come out to be low because we spend most of the time indoors. Yeah. And there has been speculated to be has a role in the increase in the allergies worldwide because of the low vitamin D. There have been few papers also. But the point which is not clear, which is not right, that, well, the association has been found, but whether giving vitamin D supplement is going to have a beneficial role in reducing the allergies, that is not there. And few papers have specifically done that, and they haven't found any better results than placebo. Okay, so vitamin D low can be associated with allergies and its increased prevalences. It is there, but it does not translate it into that you give vitamin D. Well, you can give the vitamin D for the other reasons, for the general improvement of the thing, but always we tell them just make yourself exposed more to sunlight. That is the advice more that we can give.
and seems to protect against some food allergies, egg allergy, and all that. So it has been, I think that Soumya might be able to comment, but that seems to be have some protection against food allergies.
Yeah.
So it's not a bad thing, it's one of those things. Now used to be vitamin D, now gene environment interaction, maybe 10 years later, some other things will be playing around. So vitamin D is a term that we use for everything.
Yeah. So actually, sir, there is another paper which I was coming across, that vitamin D, if there is hypovitamin D, what we are discussing, that may also shift from the Th1 to Th2 mediated immune reaction. So I think that is why we also need to target this hypovitamin diosis, so that we can address that issue, that immunological shift. So I think we had a long discussion today also in this topic, and started with a excellent deliberation by Professor Vedantan sir. As always, sir enlighten us with his deliberations. Also, we have a detailed panel discussion by Dr. Moitra sir, Dr. Krishna Mohan, Dr. Soumya, and Dr. Gayatri madam. So I'm really thankful to all of them on behalf of Indian College of Physicians. I want to thank you all for joining us today. So this is our third module. We have another 3 modules left. So may I now request our delegates to please, I think the post test you already had submitted. Next Sunday, we have another more class. So any final comments from our panelists and Vedantan sir towards our delegates?
One question I had more than comment is, we are all talking here about different things. Do they get any practical type of training in this short course?
No, sir. This is totally online one. So there is no practical exposure. So actually ICP, that is Indian College of Physicians, had taken one initiative to increase awareness about some neglected areas. So there are some more discussions on different other issues like neurological imaging, like paper publication. These are very less discussed topics. So this time, Dr. Jyotirmoy Pal, who is Dean of Indian College of Physicians, had also introduced this basics of allergen immunotherapy, because again, this is an area where we need more and more awareness amongst the physicians. So that is why this has been made, this course had been made, and this is a very basic type of course. We want to sensitize our physicians about this concept of allergen immunotherapy first. And later, if we have some chance, we can conduct some workshop. Even we have our Epicon, next Epicon is in Delhi 2024, or in Kolkata in 2025. We are trying to organize some workshop from the practical standpoint, but this type of program, this is the only online sensitization program on basics of allergen immunotherapy, sir.
I can give you one suggestion if possible, because we have we have hundreds of doctors through different programs in practically in lots of towns across India. So if we can work with Indian College of Physicians, we might be able to arrange short, small groups in all these different towns just to teach skin testing. Just do skin testing.
Great, sir. Great, sir. So
it could be done in 100 locations. Instead of one big place, they can do it in their hometown. And our graduates can teach them, because we rather would like them to do few skin tests than do this immunocap and this and that, all sorts of tests, So a few skin tests can be taught. How to do it. It can be taught in all these locations. This is just an idea. People, there could be different views about it. This is my personal view.
I think this is a great idea, sir. We can coordinate with you, and we can have a plan on this in future, sir. So thank you for these suggestions. Thank you.
Namaste.
So may I invite other panelists if you have any final comment for our delegates?
What I want to tell to all the delegates is that means allergy science is a very specialized topic, and what we're talking in this forum, like this prick test, this specific IgE test, this allergen immunotherapy, they are basically very specialized treatment modalities which have a definitive impact on a patient's disease per se. So even nowadays, as few of the forum I see, there is a pro-con debate on the allergen immunotherapy. So that is really why at this juncture one should have a pro-con debate on allergen immunotherapy for say for allergic rhinitis. There's no debate about it. So that means this one should always understand that this modality of the treatment has its own place, and it's a niche area which has a big impact on the people suffering, and it has lots of impact on it. So always see this test and this modality of treatment in the proper light. Try to read about it, get more training into it, the hands-on training and other training which is being imparted at various parts of the country, and understand the topic well. So then only you'll be able to use it correctly, judiciously, in the right manner, in the proper light. So there are two there are two ends of it. Like one who says that it's nothing, but it's not going to solve anything, and another who are using it indiscriminately and also not judiciously. But any patients coming and writing allergy test and not knowing what is the result, to do patients also confused and being a bad name to the entire specialty. So we have to stop that. So this kind of sensitization program, it should sensitize all who have been attending this to understand it and make them more, or they should strive to understand more and get more trained into it so that it can develop as a proper specialty in our country in the time to come in the future.
Very good point, Saibal. I can just add one thing, if you allow me. Exactly. This can be done because Dr. Balachandra at Medtrain, Bangalore, is offering this allergy asthma specialist course, online course, 2 or 3 days of personal contact. It serves this purpose. They train these people very, very well, and there is no selection criteria there. Anybody who is interested, who is a physician, allopathic physician, who wants to learn it, if I'm telling it right, they can enroll in these things. So this is the best way, because to get the specialized training like diploma and allergy and that is quite hard, those courses. But to get this online course training, I think it's a great idea to address that particular issue.
So any final comment from Dr. Pandit, madam?
Same as Dr. Moitra has already spoken, it is basically to sensitize. This kind of a program is to sensitize for you to know how the allergy field is. It is something like, career counseling, as in how that allergy counseling looks like, allergy practice looks like, and when you are interested, take up in that.
Just to show that we are not crazy.
So now may I request Dr. Mohan sir to have that final comment, please?
Yeah, nothing more to add, Dr. Shambhu. First and foremost, I would like to congratulate you for this great initiative. And I feel even now, unfortunately, in India, allergy practice is a little bit irrational. Many irrational practices are still going on in the allergy evaluation as well as management. So I hope these type of programs will definitely help to create awareness, and so that it becomes more rational. So thank you once again.
Thank you, sir. Thank you. So may I ask Dr.
Soumya,
Shomya, madam?
Sir?
He needs your final comments.
So, as my other esteemed panelists have said, I think it serves as a sensitization for people who are more interested in allergy, and to streamline what is the correct practice. So I met a physician from my native just last week, and he has enrolled for this program. So he was telling that he has a lot of allergy patients in the rural setting. And hearing to the first 2 modules, it has more or less set him in the right direction as what can be optimized for that patient care. So I think the purpose of this brief course has been already been serving. So congratulations on that.
Thank
I
you.
think your reach is huge in that group. Your reach is huge, isn't it?
Yes.
Thank you. Thank you. So again, today the match time is now very close. So we have to relieve our delegates also too. So hope for the best for today's match also. So again, we welcome you all to for the next module that will be on the next Sunday. We'll start sharp at 10 a.m. So thank you all. So thank you all
you.
the panelists.
Thank you.
Namaskar.